Hey guys, Woodruff here. I am just going to do a quick short on pneumothorax type. Someone was asking to go a little bit more in depth in this. And so we're going to break down some of the types of pneumothorax or pneumothorax, maybe. I don't know how you say it when they're plural. Pneumothoraces, maybe. Okay, anyway. So to kind of break it down, here's some different terminology that you might see when it comes to pneumothorax. So if you see the word pneumothorax in itself, it's usually saying that air is the problem. There's also hemothorax, and if you think hemo usually means blood. So blood is the problem, like there's a accumulation of blood. There's also, so these are like, what's the problem? Then there's also spontaneous and iatrogenic, and these are telling you what's the cause. Spontaneous means we don't know. So if someone has a spontaneous pneumothorax, we don't know what caused it, they just had one. Where on the other hand, if someone had an iatrogenic, it's not usually, it is from a procedure or device, like we caused it. So it's like that, isn't that Taylor Swift song? Like, it's me, I'm the problem, it's me. Think the I in iatrogenic is all about that I caused a problem, which led to the pneumothorax. So this could be like a patient that we put a central line in. That's probably the most common reason for it, but we're going in to do a procedure or place a device. And in the meantime, and it's actually a known complication of this. It's not, I wouldn't say like it's expected, but it's one of the things we discuss with family and people looking to get these procedures. So anyway, hold on a second. I got this little thing in the way. All right. So then there is a tension pneumothorax, and this is what happens in this one is it starts out like a regular pneumothorax, but then what happens is that air gets trapped, and this can happen if a proper dressing isn't put on, if the chest tube gets clamped. This can happen, which is why we never clamp our chest tubes. And what do you call it? What happens is that air gets trapped inside. Like when we're treating a pneumothorax, we're creating a place for air to get out. But if we take away that, what can happen is that air builds up in that lung space. So when it builds up, it literally starts pushing all of the chest structures over. So for example, if I had a pneumo on the right side of my chest and I started getting a tension pneumothorax, it would start putting pressure because air had if it keeps expanding, think of a balloon expanding, it's going to keep pushing out and against everything around it. And so what happens is that you'll see like tracheal deviation, and this is really serious. Like this is an emergency. We have to take care of this immediately, or they can have they'll go into complete cardiac arrest because it starts putting pressure on their airway. It starts putting pressure on their heart structures and everything as well. And then a chylothorax, which I'd never actually seen or heard of. It's very rare. This is where there's an issue. I believe it's something like in the thoracic lymph system. There's something that gets messed up. I'll talk about it more when I talk about solutions on the next slide. But what happens is lymph fluid from the GI system accumulates in the lung. And so the way I remember this is like there's chyme is digestive contents, and then if you put YL backwards, it's LY for like lymph. So if that helps you to remember chylothorax. But yeah, chylothorax is lymph fluid that's in the GI system, from the GI system that gets in the lungs. But hopefully this helps to break down more like what's the differences between these different types and causes. Usually, we definitely most of the time on nursing school exams, we're going to focus on like the life or death stuff, like talking about tension pneumothorax. You might want to know that iatrogenic is from a procedure or a device, and obviously that hemothorax is blood. But really, we look at these things make a difference versus just understanding the terminology. We want to say, how is this going to affect me as a nurse? So why does this matter? And effectively, it matters because it changes what the overall treatment's going to be. So no matter what, in general, for a pneumothorax, hemothorax, chylothorax, etc., they might need some sort of drain or chest tube. So the overall treatment is a chest tube, but you want to think about, but what more specific? So like as a whole, we treat the general problem of having something in the lung that's not supposed to be there with a chest tube. But there's other specific things like with the hemothorax, we're not just getting rid of air, they're also going to be losing blood. And sometimes, like when we first put that chest tube in, they can dump 600 or 700, which is almost like it's getting close to 2 units of blood out of their lung. And so we really want to be concerned about hemodynamics. We want to watch their blood pressure closely, and be watching, for watching their hemoglobin and making sure that they're not having too much blood loss. Keep a close eye on their blood pressure and everything. Attention pneumothorax is an emergency. So this is not one where we wait around, get pictures, blah, blah, blah. We do what's called a emergent needle decompression, and or we sometimes call it a DART, in the emergency room. And so we have to take care of those like that. Like, we don't wait around. We're not, talking about it for a while. We are getting straight to business and getting some, because remember, with tension, there's that air that's trapped and we need to immediately release. It's that balloon that's expanding and pushing on all those structures in the chest and can lead to complete cardiovascular and respiratory collapse. So we need to immediately take care of that. And then I read up about the chylothorax, and because it's actually a thoracic duct issue, they do require bowel rest a lot of times, and they may need a procedure to fix the thoracic duct. Now, I have never seen that on a test or heard anyone talk about that in nursing school. Depending on where you work, maybe you might see it more often, but I wouldn't spend too much time on that. I haven't really heard a lot about that. As the nurse, as a whole with chest tubes, we want to note the color and consistency. It tells you a lot. So, we had a patient that had, they didn't have a pneumo, but they had a pleural effusion. And, anytime we put a chest tube in, we always want to look at the color. And at first it was, serosanguinous, which would be expected. But then there was pus coming out, which tells me, hey, there's infection here. So we always want to look at what's coming out. Is it blood? Is it just general pleural fluid, which kind of has, that yellow or maybe like light orange tinge color. Or is there, definitely want to note if there's blood in there or any signs of pus or other things. Like with the chylothorax, I think sometimes it is kind of like creamy colored. So you always want to kind of notice what's coming out. So overall, the big picture with all of these types of injuries is we want to restore normal lung function and reinflate the lungs. So that's really what we're focused on. So yeah, hopefully this helped to break down and make it more simple what's going on here with these different types of pneumothoraxes and other things. And yeah, if you have additional questions, just let me know. Have a great day.